Dr. Ramashan, President of IPS South Zone, Dr. Arvind, Chairman, CME, my co-chairperson, Professor Vidumar, Dr. Jayant, and Dr. Arun. I'm extremely delighted to chair this session on a very lively topic, which has already been introduced by Dr. Ramakrishnan. Both the speakers, they are very eminent clinicians and academicians from a place, the Center for Addiction Medicine in NIMHANS, the premier institute in our country, and of course the Center of Excellence, which deals with addiction disorders. With regard to these topics, alcohol dependence, it always it will ignite interest in clinicians because patients who are treated even in the best centers, even the most motivated patient is likely to relapse. Relapse is the rule. Even though we have our pharmacological as well as psychotherapeutic or non-pharmacological approaches to handle the relapse part, we all of us will agree that the results are not that very great. A lot of things have been happening in the field of addiction, especially with regard to alcohol and other chemical addictions, and also the newly introduced concept or newly emerging problem of the behavioral addiction. DSM-5 has actually united the abuse and dependence, everything under the use disorder, the substance use disorder. So that is, nosological advances are there. Craving has been introduced as a part of a diagnostic criteria for addiction disorders. So on the nosological side, there are changes. And on the pharmacological side, we find there are several new molecules getting introduced. Several new targets are being identified apart from the conventional GABA and the dopaminergic. We target the 5-HT3 receptors, we target the cannabinoid system, the orexin system. So all these new targets emerging and better understanding of the neurobiology of addictions. It is definitely, I think we can hear from the master, Dr. Jayant, about the newer advances in alcohol addiction management and the newly introduced or newly emerging concept of neuromodulation in the treatment of addictive disorders. I understand that Dr. Jayant has done some work on transcranial RTMS in patients with alcohol addiction. I don't know about the other condition. And the second topic on the internet gaming disorder, which has again found a place in DSM-5, the nosology of still which is unclear. And I have heard from sources that NIMHANS is having a special clinic called SHUT, Service for Healthy Use of Technology, done under the aegis of CAM. So we are all eager to hear from Dr. Kandasamy about your experiences on internet gaming disorder. Many young children, they even find it, they think that they got into a lucrative business opportunity or a professional opportunity, which we do tend to consider as a disorder. I don't have any much expertise in this area. So I think that my co-chair Vidhu will just say a few words and straight away we can start the session, and we are eager to hear from both Dr. Jayant and Dr. Arun Kandasamy. Thank you. Over to you, Dr. Vidhu.
Respected President, the speakers, the organizers. At the outset, let me thank the South Zone for giving me this opportunity to chair this session. And I'm not prolonging my introductory speech. Probably in alcohol dependence, as Dr. Varghese said, probably preventing a relapse. What recent advances has to contribute to relapse prevention? That is probably everybody will be looking forward. And second thing, in internet addiction, even after 25 years of introducing the concept, it has failed to reach the nosological status, the construct, except for the gaming part. internet addiction has not reached the, has not assumed a nosological construct. Why is it so? Whether advances in neurobiology will be able to help to evolve this construct. We want to hear from you, both Dr. Jayant and Dr. Aripiprazole. Thank you.
Okay, so a very good evening to everyone who's present here. Honorable chairpersons for this session, Dr. Varghese and Professor Vidhukumar and Professor Varghese, and all the organizers, the President of IPS South Zone, Professor Ramakrishnan, as well as Dr. V.K. Arvind and Dr. Rajesh, as well as the sponsors for today's event. It's indeed an honor for myself to be able to talk to you today on this quite important area, as has already been mentioned by the two eminent chairs for this session. It is a very vast area, alcohol dependence, recent advances. And so obviously, given the want of time, wherein we just have about 20 minutes to half an hour to discuss this vast area, I will be focusing primarily on the pharmacological advances that are there as far as management of alcohol dependence. Some of it will be relevant to us in our day-to-day practice. Some of it will be probably more relevant in terms of our understandings and about things that are going to happen in India, say in the next 5 or 10 years. But I hope that it will be a useful session for you. So I'll just share my screen, just one second. Okay. Are you all able to see my screen? You can just give me a thumbs up if you can see. Okay, yes. Great. Wonderful. Okay, so let me introduce myself. My name is Dr. Jayant Mahadevan. I have done my DM in addiction psychiatry from NIMHANS, and I'm currently working as assistant professor of psychiatry at the Center for Addiction Medicine at NIMHANS. Now, whenever we are talking about a topic on alcohol dependence, these are some of the key areas that we need to cover. One is, of course, the neurobiology. The other is with regards to assessment. Finally, pharmacological and psychological interventions. Now, as I had mentioned, given the want of time and given the vastness of the topic, I am not going to be able to touch in great detail about all of these areas, except for specifically probably a little bit more about the pharmacological and other somatic interventions for alcohol dependence. But that being said, I think it is important that we should just briefly talk about neurobiology of alcohol dependence. These are all areas which most people who are familiar with the literature over the last 10 to 15 years will be aware of. But I thought it would be good to have a quick revision. So as we know, the stages of the addiction cycle as given by Koob and Volkov, the 3-stage cycle which moves from the binge intoxication stage, where the neuroanatomical structures include the ventral striatum, the dorsal striatum, the globus pallidus, and thalamus. And that basically subserves the part of the addiction cycle which is associated with the initial euphoria or rewarding effects of drugs, as well as the formation of habits over time. Then you have the next stage of the addiction cycle, which is the withdrawal negative affect stage. The structures which are involved are once again, the ventral striatum, as well as the amygdala, the bed nucleus of the stria terminalis, which are known as the extended amygdala. And these are associated with essentially the manifestations which are there during withdrawal, and that includes physiological signs of withdrawal as well as the motivational withdrawal state, which includes dysphoria and other negative emotional states. And then finally, we have got the preoccupation anticipation stage, which corresponds roughly to the craving part of or the relapse part of the whole addiction cycle. And the structures which are involved are primarily the anterior cingulate as well as the prefrontal cortex. So again, this has got more to do with executive dysfunction and control over craving and so on. right? So after this quick review, this is important to understand because in addition to the structures which are involved, there are also different neurotransmitters which are involved. As Professor Varghese had already mentioned, obviously, when it comes to dealing with the binge intoxication stage, the primary neurotransmitter that is implicated is obviously dopamine, although most drugs of abuse and some addictive behaviors also ultimately converge on the dopamine pathway through different neurotransmitters. As far as the withdrawal negative affect stage is concerned, that is where there is a great deal of interest in terms of identifying newer targets at a synaptic level to be able to deal with alcohol dependence. And so the neurotransmitters, again, dopamine, because there is a dopamine deficit state in the withdrawal negative affect stage, but also some of the other neurotransmitters which are associated with both the hypothalamic as well as the extra hypothalamic stress systems. And those include things like corticotropin releasing factor, dynorphin, endocannabinoids, neuropeptide Y, neurokinins, and so on, as well as orexins and hypocretins. So these are some of the other neurotransmitters which are actually associated primarily with the withdrawal negative affect stage. And so there are some medications which have been or are in development and have been used which target some of these neurotransmitter systems as well. And when it comes down to dealing with the preoccupation anticipation phase, the primary neurotransmitters that are involved are dopamine and glutamate. So this is a table which just summarizes some of these findings that are there. And I think this needs to be something which we have to keep as a kind of template which we can use to be able to understand things going forward. All right. Now, with that very brief update about neurobiology, I'm not actually going to go into a lot of the updates about neurobiology because, again, I think that will involve a whole separate session because we are talking about molecular genetics, epigenetics, and so I'm not really going to go into that in a great deal of detail because it may not be very relevant. But we will quickly move on to the next part, which is with regards to the assessment of alcohol dependence. And of course, we all know that there are standard strategies and techniques. Obviously, history, examination, investigations are all very, very important as far as assessment is concerned. But I thought that it would be interesting to talk about some of the recent advances, if you want to put it that way, with regards to assessment of alcohol dependence. Very briefly, just to kind of incite some interest in this so that you guys can think about it in the future as well. So with regards to assessments, actually, this is something which is an area of a lot of research and a lot of interest, and that is with regards to identifying ongoing alcohol use or identifying alcohol intoxication using different kinds of biosensors. And this is something which there's a review that was done in 2019, which has looked at mobile alcohol biosensors. While these are at present mostly in the developmental stage, and they are being used primarily as outcome measures, say in research and clinical trials, this is something which is potentially an area of a lot of interest because having, say, a wearable device which will be able to identify alcohol in the sweat. So that is one of the devices that is used. Then there are other measures which look, so gyroscopes, which are able to actually identify that a person's hands are moving in a particular way or can identify withdrawal symptoms. And so all of these could potentially be interesting ways to be able to assess, or ecologically valid ways to be able to assess ongoing alcohol use in the future. And hopefully there will be some clinical translation about this in the next few years. The other very interesting thing which I wanted to talk about, just to kind of put it out there as well, is the role of virtual reality. And we all know about cue reactivity paradigms. Cue reactivity paradigms are essentially presentations of cues to individuals who have alcohol dependence and as a measure to be able to elicit craving, either physiological correlates of craving in terms of changes in pulse rate, galvanic skin response, or else subjective measures of craving. And so obviously initially you used to have cue reactivity paradigms using photographs. Then subsequently people moved on to developing cue reactivity paradigms paired with MRI, which is MRI-based Q-reactivity paradigms. And the new area as far as that is concerned is with regards to virtual reality aided Q-reactivity paradigms. And this is a review done in 2020, which talks about virtual reality, both in assessment as well as treatment of addictive disorders. And I think it's something which is, again, going to be an interesting area because, again, more ecologically valid, you will be able to probably provide cues which are much more contextually relevant to the individuals with alcohol dependence. And a few of the studies, there have been about 5 or 7 studies which have been done in patients with alcohol dependence. And they have actually been able to elicit very realistic measures of craving using virtual reality. And so that is one challenge that we always usually have in patients with alcohol use disorders. And and that has been to be able to get ecologically valid measures of craving. And so this might be an answer to some of that. The second important thing which I would like to talk about, again, in terms of a recent advance in terms of assessments, is with regards to how we understand outcomes in individuals with alcohol use disorders. And I think Dr. Verghese had mentioned about how, despite medications having been around for a very long period of time, relapse is the rule rather than the exception in individuals with alcohol use disorders. And so for a large number of us, relapse is seen as a failure of treatment. And there is a large amount of new data which has been there. And actually, it's data which has been accumulated over the last 2 or 3 years, including a number of these reports which have been published in leading journals like Addiction over the last 2 years, which have talked about how we need to have a different paradigm in terms of understanding outcomes in patients with alcohol dependence. So traditionally, the kind of outcomes that we've had, which is abstinence, days of abstinence, or abstinent versus non-abstinence, things like percentage of heavy drinking days, things like time to relapse, might not be the ideal kinds of measures for a various number of reasons. And so these studies, you can look at the titles: Reconsidering Alcohol Treatment Non-Responders. What is the kind of psychosocial functioning amongst heavy drinkers 3 years following treatment? So these have looked at a lot of RCTs, prominent RCTs, which have been done in the area of pharmacotherapy of alcohol use disorders like Combine and some RCTs from UK. And they have actually tried to identify whether there are other markers that can be there to be able to identify people who are treatment responders versus treatment non-responders, and how that translates into, say, outcomes like psychosocial outcomes and so on. And actually, very interestingly, people have found that people who, there are a subset of individuals who may continue to drink, but may still have outcomes similar to people who are not drinking. And so people have used things like latent class analysis to be able to analyze this. And so this is another interesting area to look at. Another very interesting area to look at in terms of outcomes is this World Health Organization risk drinking level. And that reductions in those might also be meaningful clinical endpoints in terms of being able to assess the efficacy or assess the success of your treatment with alcohol use disorders. And so these are things which I think we should also keep in mind when we are looking at pharmacotherapy for alcohol use disorders. So with that, I'm actually going to move into the meat of the topic, which is with regards to the pharmacological interventions. And I'm not really going to talk a lot about this. We all know the currently FDA-approved medications: disulfiram way back in 1949, naltrexone, acamprosate, and naltrexone injection, 380 milligram IM once monthly injection, which is not available in India, but has been approved for treatment of alcohol use disorder by the FDA. So these are the agents which are used, I think, for most of our practitioners who see patients with alcohol use disorders. They would be familiar with these medications. And so given, again, the want of time, I'm not really going to go into too much details about that. I'm going to actually move on to the next line of agents. Also agents that we use, some of which we use very, very commonly, some of them which are a little bit newer or repurposed drugs as such, and understand a little bit about that and probably see whether we can apply some of those in our clinical practice. So Nalomofin is actually the most promising agents amongst the non-FDA approved drugs. It is an inverse agonist at the mu opioid receptor, but also an antagonist at the delta opioid receptor and a partial agonist at the kappa opioid receptor. It has a longer half-life and no liver dysfunction when compared to naltrexone. And while it has not yet been approved by the FDA, it has an approval by the EMA, that's the European Medicines Agency for alcohol use disorders, since 2018. At a dose of 18 milligrams once daily, or as needed 1 to 2 hours, very similar to how you use naltrexone using the Sinclair method, is the dose that is used. And adverse effects include common adverse effects like nausea, dizziness, insomnia, headache, vomiting, and fatigue. Again, should not be used in individuals who are either receiving or expecting to receive opioids. As I said, very promising in terms of outcomes. Meta-analysis has shown that there's been a reduction of heavy drinking days per month, and that these changes persist up to 6 months to a year. And there is also a decrease in total alcohol consumption that has been noted to be present with Nalomofin. And there are a number of clinical trials in different parts of the world which are currently ongoing with regards to evaluating the efficacy of naltrexone, of Nalomofin. Unfortunately, Nalomofin is not yet available in India, but again, hopefully something to look forward to in the future. Baclofen is something which I think we are all familiar with, in the sense that it seems to have become a part of the pharmacological armamentarium of clinicians treating alcohol use disorders in India, at least. It is, of course, popular in other parts of the world, not in the US, but it's popular in Europe as well as in Australia. And in fact, France has fairly recently also approved its use for treatment of alcohol use disorders. There's no approval in any other parts of the world. As we know, it's a GABA-B agonist. GABA-B receptors are prominent in the limbic system, and stimulation of the GABA-B receptors decrease excitatory neurotransmitters as well as modulate dopamine in the mesolimbic dopamine pathway. It's been seen to lead to reductions in reinforcing properties of alcohol, and also has some impact on anxiety and alcohol withdrawal. The doses that are used, at least 60 mg of Baclofen, although a number of the trials that have been that have looked at Baclofen have looked at much higher doses, even up to 250 milligrams of Baclofen. Typically preferred in our population, I mean, from our experience, usually the doses that we go up to are anywhere between 60 to 80. And some individuals are there wherein we've tried doses between 100 to 150 milligrams of Baclofen as well. I personally have not gone on doses higher than that. Lot of adverse effects, some common, some a little bit less common, but quite severe. The common adverse effects include constipation, dizziness, drowsiness, fatigue, headache, nausea, sleeplessness, and pedal edema. Pedal edema is something which can occur quite often with Baclofen, and it is something which is quite distressing as a side effect for individuals. In addition to this, some of the more uncommon side effects, but quite serious, are severe allergic reactions. Urinary complaints. So a lot of people actually complain of dysuria when they are using Baclofen. Agitation and chills, and sometimes a loss of muscle tone and seizures can also be noted to be present with Baclofen. And generally, I think one of the concerns with Baclofen the world over is with regards to some of these adverse effects. Although in our clinical practice, we don't probably see that much of it, but it probably needs to be evaluated in a more systematic way. And as a consequence of that, actually, a number of people have tried to look at other allosteric modulators of the GABA-B receptors, including racemic mixtures of Baclofen. So there is a current RCT which is running, which you can look up in clinicaltrials.gov, which actually looks at something called R-Baclofen, which is a racemic mixture of Baclofen, which is seen to have probably not have some of these kinds of adverse effects which are associated with the usual Baclofen that is there. And so this is basically the Cagliari statement. A number of researchers who've been doing a lot of work on Baclofen from Italy, who are now based in the US, have actually released this statement saying that there is quite a lot of evidence to actually suggest a point towards the potential efficacy of Baclofen. And this definitely calls for additional larger studies, but also emphasizes the importance of tailoring doses based on safety, tolerability, and efficacy. And I think that's a line that we need to really keep in mind when we are treating individuals with Baclofen. I do anticipate that a lot of the practitioners here would be using Baclofen in their practice. And I think these are the concerns that we need to keep in mind when we are prescribing Baclofen. The other agent, which is somewhat related to this, it's not really a recent advance. I mean, in the sense that it has been used in, particularly in Italy and Austria, in the continent of Europe, for almost 20 years right now. And in fact, there are some very interesting papers where they have actually prescribed it to large numbers of individuals with alcohol use disorder. When I say large numbers, I'm talking in terms of lakhs of patients with alcohol use disorders. And we know it, I mean, the other name for sodium oxybate is gamma hydroxybutyrate, and GHB, as some of us may know, is also an agent which, when it is used on the street, is a drug of abuse. But individuals who have actually used sodium oxybate in practice seem to report very, very good results. And very recently as well, so the study which is there below, right? So the one in 1996, that's an open multicentric study. That was the first study which looked at this sodium oxybate in 179 alcohol-dependent subjects. And they found that there was significant incidence of complete abstinence in individuals with alcohol dependence. And the same group, which includes Giovanni Addolarato, has actually looked at the efficacy and safety of sodium oxybate in alcohol-dependent patients with a very very high risk drinking level. And they've actually talked about significant increases in abstinence rates compared with placebos, and risk ratios of 6.8 in favor of sodium oxybate. So that's huge. I mean, a risk ratio of 6.8. I'm not talking about a number needed to treat. We're talking about the likelihood of response being so much higher is something which is quite miraculous in that way. But obviously the concerns are with regards to abuse potential. And even these trials have actually reported that a number of people used to escalate their doses. So the 96 study talked about 10.1%. So that's almost 1 in 10 individuals who actually escalated their dose and were at a potential risk for abuse as well. But this is another interesting agent, which at least in research settings is something which we will hope to study at some point of time. Now, moving on to another GABAergic agent. So again, I'll tick off the standard ones first, which focus on some of the known molecular targets, and then we will move on to some of the more exotic stuff. So gabapentin is another agent which inhibits voltage-gated calcium channels and therefore indirectly modulates GABA. Doses, there is a wide dose range which has been actually tried in clinical trials, from very low dose 300 mg to up to 1200 to 1800 mg. So the dose that is generally recommended is 300 to 600 mg thrice daily. And actually, quite interestingly and surprisingly, when we were going through the evidence, I mean, when we were actually going through the guidelines 2 or 3 years ago, we found that it had popped up in the APA guidelines as a second-line treatment for alcohol use dependence patients. And then actually that led us to go back and look at, do a little bit of a literature search with regards to gabapentin. And so particularly in the US, there seems to be a lot of interest in looking at gabapentin. Although the first trial that I've mentioned there in 2018 was actually conducted in Thailand. And there, a very low dose of gabapentin, 300 milligrams, actually significantly reduced the percentage of heavy drinking days and weekly drinking days. A more recent trial, which very recently concluded and was published in late 2020 from a group in the US led by Ray Anton, talked about a dose of 1200 milligrams significantly associated with a decrease in heavy drinking days and an increase in total abstinence. And they found these effects were much more pronounced in individuals who had more alcohol withdrawal. And so a recent meta-analysis, which has also looked at gabapentinoids, which include gabapentin as well as pregabalin, point towards the fact that people who have more alcohol withdrawal or prolonged alcohol withdrawal might actually benefit from the use of gabapentin. And so that's something which we can potentially keep in mind. People have also tried to look at a long-acting preparation of gabapentin called gabapentin enacarbil. And that is something they've recently concluded a trial about to about a year ago. But that was not found to be significantly better than placebo. It was a large RCT, but that was what we had seen with gabapentin. Another agent which seems to have really come back into vogue right now, with a lot of people actually looking into it, is topiramate. Now, topiramate again is something, the proof of concept studies were actually done by Banco Johnson back as far back as late 1990s, early 2000s. And people didn't really take to it very much at that point of time. From a molecular standpoint, it primarily it antagonizes glutamate receptors, both AMPA and kainate, as well as facilitates GABAergic activity. Broad range of actions, blocks L-type calcium channels as well as voltage-dependent sodium channels, and it inhibits carbonic anhydrase, which is what is related to some of its adverse effects as well. For alcohol dependence, the doses that are required are quite high, higher than what is usually used for seizures, 200 to 300 milligrams per day in a BD dose, and a lot of side effects: dizziness, paresthesia, psychomotor slowing, memory or concentration impairment, nervousness, taste perversion, pruritus, and weight loss. That being said, despite having a lot of these kinds of side effects, the APA guidelines in 2018 offers topiramate to moderate to severe alcohol use disorder patients who have a goal of both reducing alcohol consumption as well as achieving abstinence. And it seems to help with both of these, which is wonderful. Can also be given to people who prefer topiramate or those who have not responded to naltrexone or acamprosate. So again, it seems to be a good second-line agent which is used in individuals with alcohol use disorders. Again, very anecdotal, but it seems to while we find that it takes time in terms of titrating the doses, it seems to help in our patients with alcohol use disorders as well, severe alcohol use disorders. So as I mentioned, the one consideration that one needs to keep in mind, I've not put that on the slides, but keep in mind that when you're titrating the dose of topiramate is in that sense very similar to lamotrigine, insofar as you would want to titrate the doses very, very slowly, because if you titrate them very fast, then you're likely to get more adverse effects. So 25 mg start off with and build it up by 25 mg probably every week, and reach a dose of about 100 mg, and then subsequently after that probably you can titrate by increments of 50 mg, and that should be based on tolerability of the individual. It's something that is very freely available here in India. It's actually more reasonable than naltrexone as well as acamprosate and baclofen if you give baclofen at a good dose. And so that is potentially an agent which can be considered in individuals with moderate to severe alcohol use disorders in our practice as well. Zonicemite is another agent which has a similar receptor profile to topiramate. And so as a consequence of that, people are kind of looking to explore that. It also seems to have a slightly better side effect profile. And so compared to placebo, this is an old study which was done, which looked at zonicemide at a dose of 500 mg per day. Again, seemed to reduce number of heavy drinking days, drinks per week, as well as alcohol craving. More recent trials have also been done, and they are ongoing at present. Ondansetron, because again, we talked about looking at the serotonergic system. It's a 5-HT3 antagonist. Again, studies have been done way back, but again, there has been a resurgence in interest, and I will tell you why somewhat a little bit later. And primarily, again, it is seen to help with people who have a high drinking as well as early onset alcohol use disorder. The doses that are used are actually much smaller than the antiemetic doses. So 4 micrograms per kg given BD. So the best dose in the trials that were done, they tested 1 to 16 micrograms per kg doses. The most effective dose was 8 micrograms per kg. That is 4 micrograms BD. And some mild side effects are there, but generally very well tolerated. Now moving on to some of the things that maybe we may not have heard of. Prazosin and doxazosin, these are alpha-1 adrenergic receptor antagonists. We do know a little bit about how prazosin has been used in PTSD. So the proof of concept for these studies actually came from individuals with comorbid PTSD and alcohol use disorders, primarily from the US Veterans Administration, because they have a lot of people who have PTSD and alcohol use disorders. And so what they've actually found is that prazosin at a dose of 16 milligrams per day in 2 to 3 divided doses seem to actually help not just with PTSD symptoms. In fact, ironically, it didn't help that much with PTSD symptoms, but it seemed to help quite a lot with alcohol use symptoms. And that is why there have been some trials which have looked at this going forward as well. Doxazocin, again, this is another agent. Both prazosin and doxazocin, of course, have also been used for treatment of benign prostatic hyperplasia. And again, at a dose of 16 milligrams per day, this is a single dose for doxazocin. And there is a lower frequency of the kind of adverse effects that are there with prazosin. A couple of the trials which have looked at their effects in alcohol use disorders say that it seems to be moderated by pre-treatment BP. So people with higher baseline blood pressure prior to treatment initiation seem to do better with prazosin and doxazocin. There's been a recent meta-analysis which has been done, published in 2020 as well, where there seems to be some effect on alcohol consumption. So this is also an agent which can potentially be looked at, and particularly if you're able to identify individuals with comorbid trauma and so on. Another agent, I know antipsychotics is something which a lot of people have thought about with regards to alcohol use disorders. Generally, not very good efficacy. In fact, we know that the typical antipsychotics might actually worsen substance use disorder and increase substance use. But there has been some evidence to look at aripiprazole, and this is something which has again been coming up again and again, and there are a few more trials which have been looking at it. So at a dose of 15 milligrams per day, it seemed to decrease alcohol self-administration in those with low self-control, as well as delayed the return to drinking in those with high impulsivity. And this effect seemed to be moderated by the DAT1 polymorphism through alcohol Q-elicited striatal activations and self-administration. So basically what it said was that primarily there might be an interaction between the genotype as well as Q reactivity in the striatum, which might be moderated by aripiprazole at a dose of 15 milligrams. They've tried higher doses as well. Higher doses don't seem to be doing much better, and they lead to more adverse effects. So this is something which can potentially be tried out, and there are more studies which are looking into this. Varenicline is another agent. Again, we know it primarily in the context of smoking cessation. Again, people tried it in individuals with smoking cessation who have comorbid smoking and alcohol use, and saw that it also had some impact on alcohol use disorders. Again, reduced drinking, craving, self-administration, and subjective reinforcing effects of alcohol may be effective in individuals with less severe alcohol use disorder and comorbid tobacco use. And actually 2 studies have replicated this about it being more effective in men rather than women with heavy drinking. And the dose is similar to what is used in tobacco cessation, which is 2 milligrams per day. Now, some of the more exotic agents, Vasopressin, that is V1B receptor antagonist, ABT436. There is a single double-blind trial which has looked at this, and it has found a greater percentage of abstinent days. I actually looked at whether there is any evidence for some of the other typically available vasopressin receptor antagonists, that is the Vaptan group, tolvaptan, conivaptan, all of those kinds of things. But for some reason, I was not able to identify any trials in alcohol use disorder. So maybe we may need to look into this a little bit more, and these could be potential areas for study in the future. Basically, the idea is that vasopressin is actually associated, vasopressin antagonism is actually associated with decreased levels of anxiety and managing withdrawal, prolonged withdrawal in individuals with alcohol use disorders. And that's the idea of trying a vasopressin receptor antagonist. Now, a whole lot of other agents have also been tried in terms of, again, looking at being able to handle some of these neuromodulators, which have looked at being able to handle some of the withdrawal negative affect related issues in alcohol use disorders. So mifepristone is a glucocorticoid receptor antagonist. It has been tried for improvement of cognition and affective symptoms, and there's some preliminary evidence. Again, these are all proof of concept studies. Again, ibudilast is a neuroimmune modulator. It comes down to the immune theories of alcohol dependence, and it inhibits phosphodiesterase 4 and 10. And again, proof of concept studies have looked at reduction in alcohol-induced stress and cue-related responses. These have all been tested in animal models. These are proof of concept studies in humans. So these are things which are likely to actually emerge in the next 5 to 10 years. again, cycloserine, oxytocin, N-acetylcysteine, ghrelin receptor inverse agonists, neurokinin antagonists, as well as nociceptin receptor antagonists, all in the pipeline over the next 5 to 10 years. Again, the primary areas that are focused as far as this is concerned is, again, the withdrawal negative affect stage, so-called the dark side of addiction by George Koob, as well as some things to do with relapse, because we know that the withdrawal negative affect actually predisposes to relapse as well. Another few things, I just have 2 or 3 more slides. Ketamine is another very interesting agent which has been explored in individuals with alcohol use disorders. This was a paper that was published in the American Journal of Psychiatry in 2020, February. And this is a single intravenous administration of ketamine in a small sample of individuals compared to control group which received anesthesia with midazolam, and there was a significantly increased likelihood of abstinence, delayed time to relapse, and reduced likelihood of heavy drinking days. The observation period for this single administration of ketamine was 21 days. So they observed this for 21 days after this single administration, and this was an RCT as well. And so that is again an area which probably merits some amount of exploration, because ultimately ketamine is an NMDA receptor modulator antagonist, and it can be associated with undoing some of the memory related issues, consolidated memories which are associated with relapse to alcohol use disorders, and that is what the potential mechanisms could be. Now, coming to neurostimulation, like Dr. Varghese had mentioned, RTMS is something which has been tried a lot in individuals with alcohol use disorders. Primarily, they've looked at high frequency stimulation to the DLPFC, and outcomes have been fairly variable. My research work during my DM was also on RTMS, but on a different protocol of RTMS called theta burst stimulation, again to the dorsolateral prefrontal cortex. And there was some early evidence of some changes between 2 of the groups. We had studied 4 groups in this, and I'm not going to go into a lot of details about this for want of time, but again, some promising evidence with regards to RTMS. There's also a lot of exploration of using deep RTMS, that is RTMS say to structures like the medial prefrontal cortex to target craving, as well as the insula, which is something which is being explored in individuals with alcohol use disorder. As far as TDCS, which is another brain stimulation method, again, I'm quoting a study which was done here at NIMHANS, where they have looked at right anodal and left cathodal DLPFC TDCS, which again they looked at both functional connectivity using resting state fMRI as well as looking at clinical measures. And they found that there was an overall improvement in whole brain network efficiency as well as interregional connectivity within local prefrontal subnetworks. So again, the reason why I'm mentioning this is because the proposed mechanism of actions for RTMS and TDCS to the prefrontal cortex is mainly got to do with improvement of executive functions. So you're looking at executive control over craving actually improving, executive control in terms of impulsivity improving with these kinds of protocols. So those are the kinds of treatment targets that have been there using brain stimulation. Right. Finally, another interesting area is actually the interaction of receptor polymorphisms or pharmacogenetics along with treatment response. Now, most of the common agents that includes naltrexone, topiramate, ondansetron, as well as acamprosate have been studied in terms of pharmacogenetics. In fact, there are two current ongoing large studies, pharmacogenetic studies, which are ongoing for evaluating pharmacogenetic interactions of topiramate as well as pharmacogenetic interactions of ondansetron, both by the author mentioned here, that is Henry Kranzler. And this is based on some preliminary evidence, which again said that this particular polymorphism in the GRIC1 gene was associated with fewer drinking days in individuals who had the CC genotype, as opposed to the AC or the AA genotype in individuals who are treated with topiramate. Similarly, the 5-HTT long polymorphism. That is, the LL genotype of that was seen to be associated with significant lower drinks per drinking day in individuals treated with ondansetron. And so this is again an interesting area of research going forward. So pharmacological options of long-term management of AUD are expanding, but there is still a lag as far as new drug research is concerned. And that is related to the fact that very often drugs which get tested in preclinical models don't actually transition to clinical trials. And there are various reasons for that, which I'm not going to go into right now. The selection of an agent ultimately needs to be personalized, and it has to be based on multiple associated factors. And always, while we've not talked a lot about psychosocial interventions, I think ultimately a good psychosocial intervention and a psychosocial management needs to be part of any plan for individuals with alcohol use disorder. My dream, I mean, in the sense, in the future directions, what one would like to see is probably a kind of situation wherein you have a number of predictors which you have at baseline, which would include clinical, genetic, neuropsychological, and imaging markers, which would, taken together, be able to help us to understand whether this person would respond to a particular kind of treatment. And so then we give that treatment and then actually assess outcomes, not just as abstinence versus non-abstinence, but outcomes in various ways, including functional outcomes. And so that would be the ultimate framework for being able to actually understand and treat individuals with alcohol use disorders. Thank you very much for a very patient hearing. That's my email if you would like to contact me.